Morning, everyone. Good morning, everyone. I'm going to go ahead and get started with our introduction while people are still filtering in. So welcome to Neurology Grand Rounds and the C. Miller Fisher Visiting Professor Lecture, which we hold annually and have done so for many years now, with an unfortunate interruption last year due to COVID. And Dr. Ovbiagele was our selected C. Miller Fisher Visiting Professor for 2020, but we delayed that presentation to 2021 in the hopes that it could be in person, but unfortunately we're not quite there yet. Dr. Fisher would have been 108 this past month if he were still alive. And as someone who had the good, or I would say great fortune to have worked under him and been the beneficiary of his extraordinary wisdom, I think he would be extremely excited and interested to hear today's talk and to sit with our speaker and learn a little bit more about the work that he's done. For those of you who have been off the grid somehow for the last 20 years and don't know about Bruce's work, let me just briefly summarize his credentials. He's a professor of neurology and the associate dean at UCSF, as well as chief of staff at the San Francisco VA Health System. He previously was the professor and chairman at the Department of Neurology at MUSC, where he built that department to an extraordinary degree in the 6 years that he was there. His work has really focused on evidence-based interventions in clinical practice and community settings with a focus on underserved and vulnerable populations. He has authored an extraordinary number, more than 500 peer-reviewed publications, been recognized with numerous research awards. You can look at today's handout if you would like to see a more specific description of his extraordinary accomplishments. I think what Bruce has done and that I have admired so much has really been a combination of detailed and highly sophisticated health services research, but always with a focus on actionable outcomes. What can we do with this information? How can we turn this into an intervention? And when he spoke yesterday to the stroke service, he talked a lot about shifting the focus now to intervention, policy intervention, clinical trial or clinical interventions, and also thinking about the challenge we face of having a field which does not represent the population that it could in the United States, and that we need to build a pipeline. We need to support and develop, starting probably at the very earliest levels, people who are currently underrepresented in medicine, have an interest in science, have an interest in the brain and neurology, and build those careers so that the pipeline looking forward is much richer and fuller than the pipeline looking backwards. Dr. Fisher said many things, and we owe much of vascular neurology and actually many parts of non-vascular neurology to Dr. Fisher for originally describing. But there were two things that he always emphasized with the trainees that I think are particularly relevant for today's talk. The first is be an expert in something. Be the person who's the expert in that thing and know it at a level of detail that demonstrates your knowledge and your commitment. And Bruce embodies all of those traits. He knows this field inside and out, and he is a recognized world expert in this area. And the other thing that Dr. Fisher said, which I think in many ways echoes both the patient-centered care movement, but also the concept of social determinants of health, was take a lively interest in your patients as people. He firmly believed that if you didn't know the person, you couldn't really help address the problem. And I don't know how much he really meant and thought about the implications of that for social determinants of health, but they mattered to him. He wanted to know if the person was employed or not, if they had a home to live in and someone to care for them, or whether they lived on their own or were homeless. He wanted to understand how they might, what their education level was, so that he could explain their illness to them in a way that they could understand and be a participant in some way. So I think all of those make Dr. Ovbiagele the perfect person to be delivering the C. Miller Fisher Visiting Professor Lecture this year in particular. And with that, I'm delighted to hand the platform over to Bruce and hear this wonderful talk. Thank you, Bruce.
Thank you so much, Lee. Really appreciate your generous introduction and also your great pronunciation in Nigerian tongue of my last name. Thank you very much. Appreciate that. I also want to thank all of you for this profound honor. It's really, really a privilege. My disclosures. So I unfortunately never had the profound privilege of meeting Dr. Fisher, but I will say that I have a few degrees of separation from him. And so, of course, Dr. Schramm, who just spoke, I've had the privilege and honor of publishing several times with him, especially looking at various analyses of the guideline stroke data. Steve Greenberg as well, who was the 2013 to 2014 ISC program chair and was instrumental in me becoming the 2017 to 2018 ISC program chair. And then Jeff Saber, who was my mentor as a fellow, mentor as a junior faculty member, still a mentor to me, a co-author on over 100 publications, and the 2016 C. Miller Fisher visiting professor as well. And then finally, my very first lead author paper was on TIAs, was looking at the impact of redefining the definition of TIAs epidemiologically in the United States. And of course, one of Dr. Fisher's many, many seminal contributions was really identifying TIAs and their characteristics and causes. So again, a profound privilege to be the visiting professor this year. And I look forward to your questions and comments at the end of this presentation. So what I hope would happen by the end of this is that we'll all appreciate the burden of stroke in sub-Saharan Africa. We'll be able to talk about the latest completed stroke research studies in the region, talk about or be aware of the ongoing stroke science in the region, recognize the need to develop budding stroke scientists in the region. And then finally, I'll talk a little bit about what the future holds and what we're planning to do to try and move things forward in the region. So we'll start off with the burden. And so these pie charts just show the proportional distribution of various neurological diseases globally. And so as you can see, when you look to the left of your screen, we have the disability adjusted life years. And perhaps not too surprisingly, stroke comprises almost half of that globally compared to other neurological diseases. When you look at the issue of deaths, 2/3 of the deaths globally are attributable to stroke. So stroke, of course, looms large globally when it comes to trying to tackle the burden of neurological disease around the world. This just shows the disability adjusted life years by region. And so I'll just focus you, this is globally. And so stroke is #1 globally, as we saw. But then if you look across the various regions, you see that for most of those regions, it's #1. But interestingly, for Australasia and Western Europe, it's become #2, largely because, as you will see, there have been improvements in the treatment of stroke, especially the prevention of stroke. So the incidence has gone down. However, as you can see, in North America, high-income North America, largely the United States, of course, and Canada, it's still #1. So it's clearly more work that needs to be done. And I spoke about some of this yesterday in order to try and at least move stroke off this ranking in concert with other high-income Western countries. So what's been going on over the last 25, 30 years? Well, if you look here, globally, stroke has pretty much been about flat. But if you look at what's been happening in high-income countries, there was this precipitous drop over a 25-year period. It started rising slightly again. But you can see that the difference between these two curves has separated over time. And largely that's because, of course, there have been much better treatments here in terms of prevention. But largely due to the low to middle income countries really having either an increase or not much change in their burden of stroke. We haven't really seen this change that much. And so part of what I and others are trying to do is really to try and do what we can to bring this a little bit closer. As the epidemiologic transition occurs in many low to middle income countries from the infectious burden to the more chronic disease burden, we expect that this is going to rise. And so the opportunities to try and prevent this gap from becoming even greater are immense. And so this looks at the incidence of stroke, now looking at the various continents. And of course, today we're going to talk about Africa in particular. But as you can see here, the burden, particularly in Africa and several other regions, is quite heavy. In Africa itself, you can see that in North Africa and in Southern Africa, the burden in terms of incidence seems to be the highest. The middle is still pretty high, but it tends to be much higher in the northern and the southern parts of Africa. I think the reason for this is the level of affluence is higher in both of these regions. And so that is why stroke in many ways, especially in these countries, tends to be much more prone in the higher income population than the lower income population, because the lower income population tends to eat more healthier foods, not so much processed foods, and tends to not have the transportation. And so they walk to many places in order to get from one place to another. This looks at the mortality from stroke, again, looking at the continents. And you can see, focusing again on Africa, it's kind of a little bit flipped here. When you look now at mortality as opposed to incidence, you really see it's actually in the central part of Africa you have the highest incidence. And then, of course, it's still pretty high in the north, in the west, east, and south, but really it's centrally. And that's, of course, I think, reflects the issue where the resources are lowest and fewest in the central part of the continent. And as such, when people do have strokes, their chances of surviving them are extremely low. So having said that, I know you're all probably well familiar with the continent, but just to remind ourselves, the poorest continent on Earth, 1 in 2 people in the region lives below the poverty line. I was struck by this statistic that in 1820, the average European worker earned 3 times what the average African did, but now earns 20 times what the average African does. Beyond the issue of the limited infrastructure, the disease, the conflict in the region, is the issue of a surge in the burden of neurological conditions, and in particular, a medical brain drain. So limited human resources, limited expert human resources, but even with that, when people do qualify and are trained, they tend to seek to go to other places to further train, practice, and stay, thereby, of course, depriving the continent even further of its talent. What are the opportunities? It's a growing continent. It's the world's youngest continent. 60% of the continent has its population under the age of 5. Wealth of natural resources, substantial genetic diversity, so an opportunity to do a lot of studies there. And while, of course, COVID's taking its hit, prior to COVID, at least, the GDP per capita was slowly but steadily growing. And so just to underscore what I mentioned earlier in terms of the dichotomy between incidence of stroke in high-income countries and low to middle-income countries, if you look at this listing of all the African countries, whether you look at ischemic stroke or hemorrhagic stroke, all of them have shown a significant increase in the incidence of both stroke subtypes across the board. And you can see in the central part of the region, like in the DRC or Democratic Republic of Congo, there's been especially high, almost a 30% increase. So again, just to underscore the point that across the board, there's been a significant increase in the incidence of both types of stroke in the region. Having said that, I put on this slide just to point out those countries where the change seems to be really, really, really dramatic. And so I just mentioned the Democratic Republic of Congo. When you look at the incidence of ischemic stroke, almost 30% change. When you look at Burundi, 45% change in terms of hemorrhagic stroke. But look at Burkina Faso, which is in West Africa, whether you look at ischemic stroke mortality, hemorrhagic stroke mortality, dialysis loss from ischemic stroke, really, really big changes over the past quarter of a century. Again, just to highlight those countries, of course, in some countries there have been more modest changes. South Africa, especially looking in terms of the incidence of ischemic stroke, again, there was a change, but nothing compared to what we saw in DRC. So some of us have gotten together to talk about how to shape a continental response to what we know is a significant burden and what we expect to be an escalating burden of stroke in the region. And so these are the pillars that we've spoken about, really trying to make sure that there is good epidemiological surveillance. We institute primary and secondary prevention measures. There are, to every extent possible, good diagnostic and acute stroke care facilities, appropriate rehab, and then appropriate policymaking and solid advocacy. As you will see across this presentation, what we've tried to do, at least what I've tried to do along with my colleagues, is try to do something in each realm of these pillars, just because we think time is of essence. And so if you look at stroke in particular and how best to potentially improve stroke outcomes in the region, these are the challenges on the left-hand side. But on the right-hand side, we think these are the potential solutions. One, to establish stroke care centers of excellence in pivotal sites in the region, to try and inform the public, the lay public more, to try and boost self-management and familial management support for vascular risk control, to try and task shift or share medical responsibilities, recognizing there's a lot of medical brain drain, especially for physicians and scientists, and trying to shift some of that burden to nurses and other allied healthcare professionals. And then finally, in terms of the issue of limited access to care, trying to utilize mobile health interventions and potentially relatively cheap polypill formulations. When I started doing this work, I was struck because while when you go to Nigeria, where I'm originally from, and there's a lot of poverty, but in the marketplace, you go to the market room and she has 2 mobile phones. I mean, the penetration of mobile health technologies has been quite impressive in the region. And so, of course, it could potentially be a great avenue to try and utilize that to boost stroke risk control, risk factor control. So I'll just switch gears now and talk about some of the work we've done recently, many of which have been published in the region looking at stroke. And we're grateful to the NIH for kindly funding many of these studies. So this is the Stroke Investigative and Educational Research Network, also known as SIREN. It's a 15 hospital site network. We designed it as a case control study. It involves 2 different countries, Ghana and Nigeria. Just a little bit of information about the background to those countries. So Ghana has about 25 million people. Nigeria has 200 million people. It's the most populous Black nation in the world. 1 out of 4 Black people in Africa is Nigerian. 1 out of 5 Black people in the world is Nigerian. So we have 10 cities that are involved. As I mentioned, 15 sites. 13 of those sites are in Nigeria. And so this was the original design of SIREN. Its ultimate objective was to unravel genomic and environmental risk factors for stroke in Africans. And so it had 3 core arms. One was a phenomics and community engagement arm, and we'll talk about that a little bit. The second was a genomics arm, and the third was a biostatistics and bioinformatics arm. Due to some funding issues, we ended up not being able to pursue this to the degree that we wanted within the first 5 years of the study. We were subsequently funded separately with an R01 to do this, and you'll see we'll talk about that a little bit. But essentially, we focused a lot on this and a lot on this as well. And so, as I mentioned, a case control study. The cases were adults above the age of 18 who had a first ischemic stroke within 8 days. Controls had no evidence of stroke or myocardial infarction, whether they had risk factors or not, and they were matched to the cases on sex and age and ethnicity within Nigeria and within Ghana. These were the exclusionary criteria. We recruited 4,000 subjects for cases and 4,000 controls. And so far, this is the largest, by far actually, the largest investigation of stroke in the region. And so just to show you the algorithm that was instituted for investigating stroke patients, not unlike what we do here. And so a very comprehensive approach to really trying to discriminate stroke and work it up properly and subtype it properly for the SIREN patients. A look at some of the many variables we collected, span the gamut from personal and lifestyle factors, socioeconomic, of course, the routine neurological assessment, really precise subtyping, neuroimaging, and a whole host of blood tests and genetic markers were obtained. In terms of data integration, we had neuroimaging data stored. We had a very comprehensive lab information system. We used REDCap for SIREN, and it constituted over 1,700 clinical and lab variables. And also, of course, we collected genomic data. But as I mentioned, just based on monies, we were not able to do what we intended to do in terms of the full genomic analysis within SIREN itself. So we started off SIREN by, first of all, trying to establish a multilingual questionnaire for verifying stroke-free status. So we kind of validated QVFSS in the region. We translated it first into 3 different languages, 2 of them in Nigeria, 1 of them in Ghana. And we found that stroke-free controls were diagnosed with a 98% certainty compared to the gold standard stroke neurologist review and neuroimaging. And what was very interesting was that even with that degree of sensitivity, once we were able to actually put in pictograms into it, we're actually able to increase the specificity much more, to the extent that it really helped, especially for those participants who had no more than a 6th grade education. So once we were able to do that, we started to apply it within the context of the study itself. We also, as part of the preamble, as we were getting ready for the study, we developed several educational videos targeting various populations. And so we had some target in primary care physicians in the region, people who could potentially refer patients to us. So that was a little bit more sophisticated in terms of how things were described. We actually made a musical video. We made one for many leaders in the community, traditional leaders in the community. And then we had just a more lay video for the public as well. So we put a lot of effort into this, and we think it actually helped us to be able to recruit the number of patients and get the buy-in from the community for the study in the various sites that we had. So this is, here you see us, we actually were in a church here, giving a presentation, again, part of the community outreach for SIREN. Here you see us, we're actually at the state assembly in one of the states in Nigeria. And this was very instructive because we got them involved right from the very beginning. So before we even started the study, we told them about the study, we gave them updates from time to time. And then finally, when the results were published, it ended up being turned into a bill and passed in this State House of Assembly. And so really is the first stroke prevention bill, was later signed by the governor of the state and became law. But it was very instructive because this was the only state where we did this, where we happened to go and update the legislature about what we were doing. We didn't do that for any of the other sites, largely because this was our primary coordinating center. There was a lot of energy and emphasis there. I wish we had done it for the other places. But again, it was a lesson for us to try and get policymakers involved very early, and some other presentations to very key groups here. As I mentioned, lots of community engagement. We created 8 community advisory boards with 52 members. So we had 15 sites. So there was a community advisory board for at least 2 sites, and surveyed over 6,000 subjects. As a result, many of the those surveyed mentioned that they were aware or they felt that stroke was a heritable disorder. But we did find that the awareness about the risk factor for stroke, again, maybe perhaps not so much unlike here, much lower, I think, but was quite low. And so obviously a tremendous avenue for improvement and engagement in that regard. But I will say, if there was anything that was a key to the success of conducting this trial and scaling its findings up, it really was the tremendous effort we put into community engagement going in. And so by the numbers, we started 20th of September 2013, recruited the first participant a year later, after many of the things that I had mentioned were done. Like I said, we recruited slightly over 8,000 subjects actually, and have over 160,000 biological samples stored. We were covered by Al Jazeera when we first started, which was quite nice, but it was great to see this move along at the time. And so this was after 2,000 cases and controls, we published this in the Lancet Global Health. And essentially, perhaps not too surprising, we identified many of those traditional risk factors that are associated with stroke. We looked at odds ratios and we looked at the population attributable risk. But very interesting findings, especially as related to the culture in the region, the issue of meat consumption, the issue of adding a lot of salt to the meal at the dining table were clearly risk factors and made their way into the stroke prevention law that was passed. And then the issue of low green leafy vegetables. In the region, people eat a lot of vegetable soup. And so we've really turned that into something that should encourage people to do much more of that, because it was protective in low intake of the vegetable soup was deleterious. And so we've been trying to take it more as a protective benefit. And subsequent analysis also showed that independently, many of the vegetable-based intake foods that they took in Nigeria were associated with a reduced occurrence of stroke. So these 10 factors that were identified were associated with ischemic stroke, and 6 of them with hemorrhagic stroke. If you look at how where there was overlap, again, not too surprising, tobacco exclusively for a hemorrhagic stroke, and then obesity, inactivity, salt intake with ischemic stroke. So a lot more of the lifestyle issues with ischemic stroke. Tobacco, of course, just with hemorrhagic, and then these other issues in the middle, there was overlap. We looked at risk factors for stroke by sex. Essentially, I'll just point out the highlight here, which was for men, having a monthly income of more than $100 was associated with a higher occurrence of stroke. And for women, sprinkled salt, that's adding salt at the dining table, was associated with higher occurrence of stroke. We looked at subtypes of stroke and broke it down by age, less than 50, over 50. For over 50, predominant subtype was small vessel disease at almost 40%. And below 50, it was large artery atherosclerosis at 40%. Very low incidence of, or relatively lower incidence of cardioembolism. Factors associated with stroke in people less than the age of 50. Again, those traditional factors were really what popped out: hypertension and diabetes. We also did some limited SNP testing, and we found that there were some polymorphisms associated with stroke occurrence. APOL1 was associated, and also interleukin-6. As I mentioned, we are doing, and you'll see as I talk later on, we are now doing CIDS genomics, which is really looking at the GWAS. And so we hope to have those more definitive information later on as we move along. And so beyond the issue of SIREN and epidemiology, as I mentioned, mobile health is especially promising just because of the penetration of mobile phones in the region. And so we designed this study called PINGS, which really looks at having nurses supervise blood pressure management in stroke survivors, in recent stroke survivors, utilizing a home blood pressure monitoring device, and also by utilizing text messages, which include motivational messages and reminders about checking blood pressure. These were results of the pilot PINGS trial. And essentially what it showed was that over a 3-month period in the PINGS arm, those randomized to the nurse supervision of these mobile health intervention, we had a reduction in blood pressure, particularly for those whose initial systolic blood pressure was over 160. And across the board, we also saw strong trends and some significance in terms of other blood pressure parameters and at different time points, especially at month 9. So we were really looking at feasibility, safety, and trying to see if there was any preliminary efficacy. And as you'll see later on, we are now conducting PINGS 2, which is the phase 3 more definitive trial. Again, sticking to that mobile health theme, this is our tele-rehab after stroke study. We started off by doing a systematic review, found out that 8 of 22 studies seem to favor tele-rehab. As part of our search, we found this intriguing app called 9Zest, which was developed in India. And so we decided that we should test it, largely because in the region, there's virtually no rehabilitation. Very, very few stroke patients get rehabilitation. One, because they don't have the infrastructure, they don't have the personnel. People travel from a long way to those safety net hospitals. So it's few and far between. So we thought with mobile phones and with an app like this, potentially tele-rehab might be the way to go. So we tested the app in a pilot study, and it seemed to have good effect on the stroke levity scale after 3 months, seemed to have decent effect on MoCA. Of course, limitations were it wasn't a randomized trial, but we are now designing a randomized trial to look to see what the effect will be compared to standard care, but looked very promising at least, and was certainly feasible. And at very best, it could potentially be an opportunity to provide hundreds, if not thousands of people with therapy that they otherwise don't get right now. This was actually our very first study in the region. This was in Nigeria, 4 sites in Nigeria called Thrives, randomized 400 patients to the intervention, which was pre-appointment reminder phone text, an in-clinic educational video, a risk factor report card, which the provider would go over with the patient, and then subsequent to the clinic, a motivational phone text, and they also kept an outpatient stroke registry. Usual care just had usual customary care. We gave them some financial incentive to stay in the trial, but otherwise we didn't do that much with them. Unfortunately, the intervention did not show benefit for the outcome, which was blood pressure 1 year post-stroke. We did see, however, that there was an improvement in the average report card percentage over the 12-month period. So patients, when they went over their risk factors with their physicians, whether it was objectively or subjectively, they seemed to be doing much better in terms of adhering to lifestyle changes, but also in terms of their blood pressure. So on one hand, their risk factors seem to have improved over time, but yet we didn't necessarily see when we checked 1 year later a difference between them and the usual care. So we're trying to dig deeper to see what might explain this discrepancy, and trying to come up with a way to design a future trial based on any potential aspect of the intervention that was positive or might have shown some efficacy. So those are the studies that we have published. These are the studies we're doing right now. And so I spoke about the issue of the polypill, trying to have a generic polypill formulation that would allow folks in these resource-constrained regions to have their risk factors better controlled. And so this is the SMART study. We are randomizing patients to this polypill. It's a polypill formulation made by Cadila Pharmaceuticals in India, contains aspirin and generic statin and 2 generic antihypertensive medications. And so we're in the through. We've actually finished enrollment. We're just in the follow-up period. We hope to have results in late summer or early fall. And then hopefully, if things look good, we will go ahead to try and have a definitive SMART trial powered to look at clinical events themselves. This is SIRS genomics, as I mentioned. This really is the arm of SIREN that we didn't really get to do. And so we are now doing the GWAS for the what we collected within SIREN. But what we're doing is actually we've expanded it, and this was what NIH was hoping for as well, that we would expand beyond just what we collected in SIREN to try and leverage other NIH-funded initiatives in Africa. So we have a lot of samples that we are now going through, and that really is the primary focus of SIRS genomics. This is ARISE, another study that we're involved in. This is just in Nigeria. Again, it's that issue, the very first pillar of epidemiological surveillance. And so here what we're doing is trying to develop a scalable, multiple mHealth community-based interactive surveillance system. So what we're trying to do again is leverage mHealth or use mHealth to try and incorporate it into how we can surveil the community for stroke on an ongoing basis. And so right now we are still in the community engagement phase, trying to educate people about it. We'll then subsequently move into developing the mHealth platform and getting this integrated database. But the whole idea again is to try and inform, engage the public, and have a way to routinely screen them using mobile health. And this is PINGS 2. I spoke about PINGS 1 earlier. We're now in the definitive trial. We have 10 sites. So far, we recruited 51 subjects. COVID notwithstanding, we're thankful for that. And so we look forward to seeing what this shows at the end of it. And then we have a separate study that has been funded, creating an African neurobiobank for ethical, legal, and social issues. The primary aim is to try and engage the community as much as possible about biobanking samples and genomic studies. And so we're in the throes of doing that. I think we're in the 3rd year right now. And so we hope to be able to report back our experiences within that. So spoken about the burden, spoken about published stroke studies, spoken about ongoing stroke studies, but the story would not be complete if we didn't discuss the need to develop stroke researchers in the region. And so why should we engage in the development of research capacity in regions like this? Well, the National Academy of Medicine strongly endorses investment in global health research that potentially by extension benefit the health of Americans, especially, of course, COVID being an example, that in many ways there are no borders. And so being able to develop researchers of high quality and are capable in these regions could generally serve the globe well. The other reason is that the neurologist population ratio in African countries, 53 of them, raised from 1 per 160,000 to none in 11 countries in Africa, compared to 1 in almost 30,000 in the US. The WHO recommends us 1 in 100,000. And then, as I mentioned previously, a lot of brain drain already. So if we can train people there who would stay there and are competitive globally, much more likely to stay. The other reason is that the truth is Africa doesn't contribute a whole lot to the world's research output. So there's an opportunity there. And so not a lot of money is dedicated towards research. And so trying to develop more researchers and more research in the region, I think, is a lofty goal. This just shows the journal Stroke and shows submissions in 2019 by region. And you can see that if you just look at Africa, very few countries have been submitting to stroke. Again, stroke being the leading journal in the field. Most of the continent doesn't submit anything at all. And even those that do, less than 1%. So again, an opportunity to try and develop people and engage them more in the academic stroke community. We've taken a look about what about guidelines? How often, what is the quality of stroke prevention guidelines, of hypertension guidelines, of diabetes guidelines in low to middle income countries? Well, it turns out, one, they don't often issue guidelines or develop guidelines. Two, it turns out that the quality of those guidelines when you apply stringent criteria is not as strong as those developed from high income countries. And we found that none of these guidelines, none of these practice guidelines emanate from Africa. As you can see in this situation for stroke prevention, I think there was one guideline from South Africa, and that was a long time ago. But really, South America is not doing too much better. But again, there's a paucity of guidelines in low to middle income countries generally, and definitely in Africa, it's an issue as well. So what we are doing, we have one training ground right now, and I'll talk about the one that we hope to get funded shortly. But this is SCART, and what we're doing, it's a consortium here in the US, including universities in Ghana and Nigeria, enrolling 100 trainees over a period of 4 years. And these trainees undergo a 2-year program, very intensive research courses in year 1, and then they have a mentored research experience in year 2. And again, the whole idea is to try and mitigate the risk of brain drain. What we hope to do is be able to develop a sustainable network of scholars with scientific research expertise. So all these scholars either have a cardiologist background or they have a vascular neurologist background. What we're excited about, potentially, knock on wood, is the talent study, which is really dedicated to neurologists of all stripes. And so this actually, fortunately, got a great score and is being reviewed by council next week. We hope it gets funded. But really, this is exciting for a number of reasons, not just because it's focused on neurology. It's a partnership with the African Academy of Neurology. And we hope to recruit 20 scholars, expose them to online training in research methodology. At the end of it, we want them to become new faculty of what we hope to develop a master's degree in neurological research at the University of Ibadan in Nigeria. So in the 4th year, we hope to transition people from having trained and everything to become the inaugural faculty for a master's degree, which hopefully will then become something that folks can get trained on within the region. I'll be remiss if I didn't talk about some of these stories here very quickly. So these are 3 individuals. I tell this story when I'm talking to some of my mentees. I met them just a little over 10 years ago, and I met them at an AAN meeting in Chicago at a poster session. They were presenting a poster, a hospital case series on stroke. Maiwa was an early stage assistant professor. Rufus and Steve were both fellows. They have been part of SIREN and all the studies that I've mentioned so far. Maiwa is now the dean of his medical school. He's the chair of the Lancet Commission on Stroke. He's doing so many different wonderful things, and he just won the World Stroke Organization Award for contributions to clinical research. Rufus has won AAN awards, so has Steve. Rufus is the founding chair of the African Stroke Organization. So, and there are generations of people beneath them, very promising, just as promising as well. So it's just been exciting to see people advance and be competitive on the global stage. And then this is the African Stroke Organization and its conference. I just spoke about Rufus. Rufus is the founding chair. Maiwa is the deputy founding chair. I'm a steering committee member. But we also have the African Stroke Organization Conference, the first conference to take place virtually, kindly funded by NINDS and a few other donors. It will be on November 3rd to 4th, first ever African Stroke Organization Conference. We're going to have mentoring career activities for a variety of scholars who will submit abstracts from around the region. But we really hope this will be the beginning of, again, building that network of capable scholars who can do research to tackle problems within the region. Summary and the future. So just to summarize what we've gone through, substantial rise in stroke burden, anticipated to even be higher, several ongoing studies, showing the nature of stroke within the region. Lots of career development initiatives going on. Ideally, as I mentioned, the research addenda will go across those 5 pillars, but for interventions, it's really important to have multi-level interventions that target the patient, the provider, the system, and even potentially the health policy environment as well. For the future, we are building out our biorepository. As I said, we're doing SIBS genomics. We are completing some of the trials I mentioned, like PINGS, like SMART, and we also have several trials which are under review, and so we hope to also continue some of that work. We've also, this was actually under Maiwa's leadership, started this consortium, SHARE. So it actually leverages the H3 Africa network, and it looks at different funded initiatives around the country that are related, around the continent, I beg your pardon, related to cardiovascular disease or stroke, including kidney disease. And we are now pulling all our data together to try and make sure we can have a very large comprehensive resource to potentially interrogate key questions that affect various aspects of cardiovascular disease in the region. And then finally, the other aspect of the future is, I think it's very important, given the excess burden of stroke on African Americans in this country, given the rising burden of stroke in low to middle income countries, particularly Africa, to try and study to compare Blacks in the US and Blacks in sub-Saharan Africa. So we started taking our first look at that, and this was a comparison of the REGARDS cohort, which is here in the US, large NIH-funded study, compared to SIREN. So this just looks at SIREN and REGARDS. So some intriguing findings, essentially showing that hypertension and diabetes are higher in Africans and African Americans compared to their European American counterparts. And then lifestyle factors which are deleterious, whether it's obesity, whether it's sedentary lifestyle, whether it is less exercise, tend to be more here. And so whether African Americans having this higher burden of diabetes or hypertension and more deleterious lifestyles are potentially being predisposed to higher risk of stroke, I think is one hypothesis that we have. There are other genetic and of course psychosocial things we want to investigate. So we are putting a proposal to the NIH to look at this, to do a prospective study looking at Blacks in Africa and looking at Blacks in the US. I've been pulled up and held up by so many people, and some of them are mentioned here. I'm extremely grateful to them. And thank you so much for your kind audience. Look forward to your questions and comments. Thank you.
Thank you, Bruce. That was just a wonderful, wow, what a great body of work and what an important body of work. Let me start by asking a question, and I'll open it up to others. You can also keep your eye on the chat and the Q&A where there'll be questions coming in. And I welcome you. I can either read them out to you, Bruce, or you can pull them up yourself. You've done a remarkable amount of work, and you've really been the one leading this work. And I know you say that it's been the result of many wonderful collaborations, but clearly you're driving a lot of this work. My question to you would be, to our faculty, to our trainees, how would you like to see them engage in this work? What's the call to action here for this group of established and evolving neurologists who are here listening to you today? What would you like them to think about? How would you like them to think differently after today?
Yeah, no, thank you, Lee, for that question. I think, so several things. I guess the first question would be, why should they care per se, right? So we have a challenge with stroke in this country. It's not as bad as it used to be. And while there's, of course, it's always great to care about what's happening elsewhere, why should they care? As I mentioned, of course, it's largely because, of course, in many ways, I think it's important to recognize that there are not necessarily borders, things kind of cut across, but also we can learn from each other. I think Africa's tremendous genetic diversity offers opportunity for us to better understand ourselves. Africans are more different from each other than, some of the differences we tend to try and point out in each other right here. So I think that's an opportunity. So it's an opportunity to do that. I think another opportunity, and it doesn't have to be with Africa, Lee. I just look at low to middle income countries across the world, and I think there's an opportunity there as well. We have, fortunately, we're a heterogeneous nation. We have lots of people that come here, and I think it's an opportunity to better understand not just people there, but people here who came from there. So I think that it's a great opportunity to be able to tap in and be involved in that. How do you do that? I think one way is to become a mentor. We are always looking for mentors. I am struck by how hungry many of the scholars in Africa are for mentorship. It's unbelievable because, again, resources are few. And so once they get a little bit of attention, they just grab it. It's amazing. So being a mentor is one way to tap into this. As I mentioned, I just happened to walk by a poster, and then we started conversing. And then that's what turned into a lot of these things. And so I think that would be the call, to try and get involved in one way or the other, remotely, potentially as a mentor, but maybe even more so getting involved in writing grants and things.
Wonderful. So Farah Mateen, one of our neurologists interested in global health, who I think you know, says, thank you for the excellent lecture. Can you speak to regional variations about stroke within Nigeria and Ghana? For example, the rising middle class having more access to care. Is there a private or public healthcare system?
That's a great question, Farah. Thanks for the question. So Nigeria is a little bit more convoluted, a little bit more complex. I'll start off with Ghana. Ghana has a national insurance system. And so that is fantastic. They have a national insurance scheme. So everybody has some kind of baseline insurance that is provided by the government. So that has been a leveler in many, many ways. Of course, the wealthy in Ghana still go on to private clinics like anywhere else in the world and get additional care. But the gap between the middle class or the rich to the poorer folks is not as great as it is in Nigeria, where there is, to the point that you're making, huge regional differences, not just because when you look at GDP in Nigeria, it's higher than Ghana, but there are very, and of course, it's a very big country. There is no safety net system. There is no national insurance system. So there are big variations. So in Nigeria, for instance, in the north, much, much poorer than the south. The south is where all the oil is. So even north to south, you see a big, big, big variation in outcomes. And we even saw that in the stroke data that we collected as well. You have more hemorrhagic strokes in the north. You have more mortality from stroke in the north. But point well taken, big disparities, largely because there's no safety net whatsoever. People are left to their own devices.
Great. Steve Greenberg asks, oh, is there someone at Lender 7 who wants to ask a question?
Yes, this is Andrea Harriet. Hi, Dr. O, how are you? So I had a question about the incidence and mortality, especially the increased incidence and mortality that you're seeing in Burkina Faso and some of these other countries. Do you think that that's attributable to enhanced epidemiology and screening and surveillance, over the past several years, or do you think that that's related to a true increase in incidence? And my second question is in relation to penetration of some of the central countries in Africa. Are you able to get more penetration with SIREN or other networks into some of the Central African countries?
Great to see you, Andrea, and of course, terrific question. So with regard to the issue of Burkina Faso, I don't think it's a great question. I don't think it's a question of enhanced surveillance, just because as far as I know, there hasn't been disproportionately greater surveillance in Burkina Faso versus everywhere else. This really has been more part of what Interstroke has been doing. And so they're surveilling everybody the same way, to the same degree, as far as I know. So, but it's a great question, but I'm not aware that they're doing anything differently that is identifying more strokes necessarily in Burkina Faso or in the Democratic Republic of Congo. Your second question pertained to, and I've forgotten what it was, Andrea, what was that? What was the second question?
Have you had any additional penetration in the central countries in the continent in terms of your work?
Right, now, thanks for asking that. And I suspect you asked that because, of course, you saw that very high mortality in the central countries. not at all. And this is the issue. The issue, of course, is one of resources largely. What we're hoping is that as we disseminate the findings of SIREN more, we can engage policymakers more. So the goal would not, of course, to do research in all the different regions. The goal would be to take limited resources, do proper studies in one region, and hopefully engage policymakers to scale things up everywhere else. We haven't done that. We've been focusing on West Africa for the most part. But I agree with you, in terms of resources, Central and West Africa are probably the most deprived. And so it'd be very helpful to try and see what one can do in that region. Thank you.
Yeah, Bruce, Steve asks a related question. Amazing work, Bruce. Prospects for extending SIREN fully to hemorrhagic stroke as well, not just ischemic stroke?
So no, thanks, Steve. SIREN actually has hemorrhagic stroke, and to the point that you're alluding to, as many of you are well aware, the breakdown between hemorrhagic and ischemic stroke is very different in developing countries. Here, of course, we think it's about 85%, 15%, 85% ischemic, but in many of the low to middle income countries, anything from 40% hemorrhagic stroke to sometimes almost 50-50, and it's similar in Nigeria. So we are doing hemorrhagic stroke, Steve, in SIREN, but we are, to your question, we focused large, so we involve those patients, but we focused a lot of the analysis that we've done on ischemic stroke. What we want to do is now do a prospective study looking at hemorrhagic stroke itself. So we've submitted a grant to the Wellcome Trust in the United Kingdom to look exclusively at hemorrhagic stroke, both the phenomics and the genomics of hemorrhagic stroke alone. So we'll see.
Bruce, one last question, and then we'll thank you and wrap up. You talked about the poly pill, and that's a very exciting intervention. Are you putting forward and/or meeting resistance to the idea of poly pill intervention in patients who have not had brain imaging? Because many of the patients in these countries don't present to a hospital or have a CAT scan, but based on phenotyping alone, is there enough trust in the poly pill as an intervention there? Or do you think with the rate of hemorrhagic stroke so high that warrants randomized trials?
Yeah, no, absolutely. It's there's a lot of, and I'm not so in being there, Lee, sometimes I wonder whether people buy into what I'm saying because they're convinced what I'm saying makes sense, or because of the desperate need there as well. And so there's always that big issue. But I will say so far, we've had no pushback whatsoever from either providers there or from patients when we explain what we're trying to do to them at all. But again, the issue is because healthcare is so fragmented and everything, once they get any attention, they just, they buy into it. But I agree with the premise that you're making.
Wonderful. Well, Bruce, we are at the top of the hour. What a wonderful lecture. Thank you so much. We look forward to hearing from you again and again and again this week because you'll have a chance to be with us on multiple occasions. And so we'll say goodbye now, and thank you so much.
Thank you very much. Thank you.
Bye, everyone.